In today's show, number 1, ER consult for a 19-year-old with erectile dysfunction. Number 2, hospitals collecting more money at the time of service. Number 3, conscious sedation billing for prostatic artery embolization. And a bonus topic, if it sucks, can you bill something extra? Welcome to episode 246 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-host Mark Painter and Dr. Ray Painter. And we want to welcome back special guest Dr. John Lynn, a solo practitioner in Gilbert, Arizona. Welcome, John. Thank you for joining us. We really appreciate having you here. Always a great show with you. And John brought us those topics that I mentioned in the intro. So let's dive right in. Well, first of all, let me say a little bit more about John. John is also the organizer of the Thriving Urology Practice Facebook group, and he's one of the moderators. And John, you want to tell us a little bit about that before we get started?
Yes, the Facebook group was founded because of a need to share information with practicing urologists in the United States. It is free, and as I like to say, if it's free, I will take 3. Urologists and practice managers, coders, billers will get together in that group and share comments, information, and ask questions regarding what to do to run their practices more efficiently. And these questions came from member comments or questions in that group. So I encourage everyone to join.
That's the Thriving Urology Practice Facebook group. Please join and share your information and gain some knowledge. All right, John, do you want to ask or bring those 3 topics? Let's go. Let's start with number 1.
Okay, number 1. This is a very short question, but it raises a lot of questions. Just got a call from the ER. 19-year-old cannot get an erection. And that was it. So the comments, there are so many comments about the entire situation, but I want to talk about this scenario and the evaluation and management coding when the patient is seen in the ER relative to medical decision-making, time-based recommendation, et cetera, when it comes to a urologist who has been forced to come in to see, if you are forced to go into the ER to see this situation, what are some billing coding considerations? Mark?
Yeah, so first, my question would be, why not ship them to the office?
That's exactly right.
I mean, that's the first thing I would look at from an overall standpoint. You know, the ER codes, which you'd have to use in the ER side of the equation, are all facility rate bills. So in addition to the time that you have to use to get over there, and then see that patient in the ER, and then track down all of his demographics and everything else, I mean, that's a loss right there. So, I mean, the first thing you could do is ship him to the office. But so that's my initial reaction is that kid's probably perfectly capable of walking and driving. Ship him to the office.
I agree. I think I'm missing some more information regarding this scenario. It's just crazy. It's just insane.
So, but then if let's say, yep, you're forced. So somebody, or you agreed, which one way or the other, you went into the ER.
Say you are a brand new urologist in the community and you want to build that rapport with the ER to get business from the ER. You go in there to see this insane consult.
Yes. Or maybe you're employed by the hospital, so you get a walk downstairs to get there. But either way, so ultimately, you know, you'd look at the presenting problem, right? As the first thing we always think about as a medical decision-making piece. And this would be like, John, is this, I mean, a lot of times we consider erectile dysfunction as kind of a chronic issue. But do we know with a 19-year-old if this is going to be chronic or not? Are we going to, I mean, where do we look at this from the presenting problem standpoint? I mean, from a clinical standpoint.
So typically for the older adult, it's a chronic problem. And if the patient is coming in to me in the clinic or possibly in the ER with erectile dysfunction, it's typically an older gentleman with erectile dysfunction. This is typically a chronic problem. And if they're seeking care in the office or in the ER, it's a chronic problem, not a treatment goal.
Right.
So that would be in those scenarios. But in this case, this 19-year-old, and as with any coding question, sometimes we don't have the complete information when the member is presenting or asking the question. So we have to assume. And so for this 19-year-old, I'm assuming this is a healthy 19-year-old otherwise. And this problem in this situation, as described, is possibly not a chronic problem, most likely not a chronic problem, not a treatment goal. It may be an acute problem. So that the reason Mark is asking me these questions is that it matters when it comes to the problem section of medical decision making.
Right. I mean, and ultimately, could this be an issue with drug, right? Or, something that the kid has ingested? Is this a performance issue? Is he got some parental issues? Like, what is going on? And ultimately, what are you going to end up treating? Is this something that can be acute or chronic? And so that would be my first piece is I need context as to what in the end that note said relative to that kid's erectile dysfunction or that young man's erectile dysfunction. So we can't make the assumption straight up that any disease state, automatically fits in one category or another. It's about the patient and the presenting problem for that particular case. So, and then then moving on to data. So we could have a level 3 or a level 4 on the presenting problem. On the data side of the equation, again, what do we know? Typically an erectile dysfunction patient, we don't see a lot of data on those particular patients. But in the ER, did they run a bunch of tests on him straight off the bat? Are we looking at a bunch of labs? What is going on around that? And that would make a difference as to where potentially you would go for the data piece of it. And then finally, the risk component is what are you going to do? What are you going to do to treat it? I mean, obviously, we kind of push around that a lot of erectile dysfunction visits hit that level 4 if it's a chronic problem, not a treatment goal, and you're changing prescriptions or giving a prescription straight up. But in this case, what is going to happen with this patient? What are you going to do to treat them? Are they, is it psychological counseling and a referral, or is it, stop using drugs? In the end, there's not enough here to really lay that out. And then, of course, the time-based recommendation, that's not an option in the ER, right? So we can't really say, should I bill this based on time? No, this is an ER visit. If you go to the ER, time is not one of those things that can override an ER visit. So you're stuck with the MDM of, what is the problem in its context? What is the data that you reviewed? And in the end, what treatment pathway did you go through? So I can't tell you from what we have where you would actually end up coding this, whether it's a 3 or a 4, doubt it's a 5, doubt it's a 2. So I'd probably be choosing between 3 and 4, but even that's a wild guess.
No, I would have to agree with you. Say this is, so there's several, like you said, there's several ways to go. Number one, billing based on time is not possible because you're seeing the patient in ER. So it comes down to medical decision-making. And in medical decision-making, you have 3 elements: problem, data, and risk. Problem, in this situation, I'm just going to assume this is probably not a chronic problem, which is not a treatment goal. So probably a level 3 problem, an acute uncomplicated, possibly. Data. Now, data is where you may end up getting a level 4 because the ER may get, well, maybe there's a cardiac issue. So the ER doc, he or she orders an EKG, checks a urinalysis, which is relatively reasonable, and maybe gets some baseline basic metabolic panel or something like that. So now you have 3 data points. which gives you a level 4 in data. And depending on the risk, whether or not you are just giving the 19-year-old some counseling, which will be a low risk type of a situation, or are you talking to the young guy, hey, this may be a psychogenic performance anxiety issue, and we can try to give you one PDE5 inhibitor to try to get you over the hump, if you will, to help you get back in the saddle, and then stop that medication. So you talk to the patient about the various treatment options, ultimately through shared decision making, come up with a decision to prescribe that one single dose of PDE5 inhibitor. So now you have prescription drug management. So in data, you have level 4, and in risk, you have prescription drug management, which is also a level 4. This is still a energy losing proposition where you bill a level 4 visit after getting out of bed, travel to the ER just to provide this advice when it could have been done as an outpatient. Back to you, Mark.
Yeah, and that is why we started at the first point. It was like, that kid should go to the office. That I mean, now you can deal with time, the time it would take to counsel him, talk to him about those things. You do have a little bit more of a workflow issue, so you can see your other patients as well. So, and you get the non-facility rate. So in all, definitely a better move to get it out of the ER. But I know it's not possible for everything. But so in the end, you got to consider, what do I have to do to serve my patients, do the right thing, and then make sure you build your context that really explains the entire situation, so that you can select the right code for the service that you provide.
Okay, let's move on to the second topic.
This one came from my local hospital, believe it or not. So this notice came from the hospital last week regarding a change in financial protocol about scheduled elective surgical procedures. And it goes something like this: increased patient responsibility. As is customary in the Phoenix market and in line with other providers, we will move the down payment requirement to 50%. We will be increasing the required patient payment for deductibles and copays prior to the day of surgery from 20 to 50% of the estimated patient liability. And I know, Mark, as you travel across the country, helping urology practices improve their operations, I'm sure you have some insights and comments about this change.
I do, and actually, this is interesting. So, when you see stuff like this happening, one of the things that I look at is what's happening with newsletters and podcasts and various meetings, and there clearly has been an emphasis on patient collections in the hospital side. It's quite frankly, it's in the physician side as well. I mean, the average patient responsibility now is 35% of your total income. That was a number that I picked up off a recent article that I read. And that's a big number, and that averages things across the board, where we know Medicare is 20%, so that drops everybody's average. So it really actually takes it to a much higher rate. And ultimately, when you look at deductibles being in the $2,500 to $5,000 range, that is, prior to any elective surgery, the insurance kicking in. And we've seen a bunch of practices that have timed their bills so that the hospital can get the full patient collection, and then the physician doesn't have to worry about collecting that deductible. There's all sorts of strategies that are out there. But the reality is, this is happening across the country. And some of the hospitals have gone to flat out 100%, and we're not going to take you. So this is not going down. In fact, I would say the Phoenix market is probably lagging from some of the other markets in the country as far as what the hospitals are collecting. And we're seeing this trickle in to a number of different practices. In fact, I was just speaking with a pediatric urologist, and the hospital charge to them on a pre-collect was $9,000 for them to take care of a very simple procedure where the physician fee was going to be somewhere around $700. And ultimately, the patient luckily had the money to actually go through all of this. But it was also unlucky because if the patient would have pushed back a little bit on the hospital, they may have been able to negotiate a lower rate with some additional discussions with that. But that's kind of taking it a little bit further than I think we really wanted to in this discussion. But in the end, I think what this does, and it continues to do, is really emphasize that the patient responsibility piece of the payment to your office really needs to be taken into consideration sooner. And we've preached for years that you absolutely need to keep track of and pick up the copay, but it is worth taking the time to pick up the deductible and start talking to the patient. And at the very least, you need to get a credit card on file for patients to pick up their deductibles, get their pre-deposits. If they're unwilling to pay you before you fix their problem, then they are going to be less willing to pay you after you fix their problem. Now, maybe it's reasonable as we think of how we deal with contractors and those types of things to let the patient have some balance owed based on results. But it can't be a big portion of that, or you're not going to get paid from the patient. I mean, that is becoming something that we are seeing as an issue, almost, we'll call it a financial epidemic of patient balances sitting on the physician's balance sheet. And with some of the state laws that are out there right now, in fact, I think California on July 1 basically is moving to a new law that if you don't have a financial arrangement with the patient before you see the patient actually has no legal obligation to pay you. They will pay you out of the goodness of their heart, or they could walk away from that bill without an impact to their credit card and without your ability to pursue them for that cash.
Wow, that's crazy.
That
It is crazy.
I got a question.
Yeah.
In this notice, at the end of it, it says of the estimated patient liability.
Yeah.
Now, are they lumping in the physician fee with that?
No, typically they're not. And the No Surprise Act is they are supposed to refer you to the physician for their portion of that. Now, if they do employ the physician, they might be able to give the full package. But, this is one of those areas where the patient has a lot of work to do in the No Surprise Act. And then it's not that it's not without burden on the physician office, the facility, be it the ASC or the hospital, but anesthesia, pathology, all those groups are going to potentially be billing the patient. And, ultimately it was, from the patient's perspective, a little bit unfair for them not to know that walking in. And I think that is a big driver in the No Surprise Act was, man, I went in for the surgery and I got the doc's fee, and now I got another, $10,000, $15,000 out there to all this stuff that I thought I was all in for $500.
John, what are you seeing from the patient side of things? Are you getting pushback, and have you had any of these 50% requirements with your patients yet?
Well, as I have semi-jokingly said, sort of, that the hospital is nothing but an expensive hobby. I've been saying that for a long time. I try to avoid the hospital. But operating at a surgery center, I know they collect at the time of service. I think when the hospital sent me this notice citing that, and in line with other providers, I think they're insinuating with other hospitals, number one, and number two, other healthcare facilities like physician offices and also ambulatory surgery centers. They're collecting more, if not all, of the patient responsibility at the time of service. And I think that's the right thing to do. The patient's contractually obligated to fulfill that responsibility, and the hospital is simply following the contract that they have with the insurance company. Now, for the urologist, you have an obligation to collect that. It is also in your contract. And if you should, you should not be doing this, but if you write off the patient responsibility and the insurance company were to discover that, the insurance company can come back and say, hey, your actual fee is whatever you stated, less the amount that you consistently write off. So your new fee will be the reduced portion. So you never want to do that.
Yeah. It's a double financial sword, right? In that ultimately, if you let it go, it could come back and force you to let it go elsewhere. So in addition to what you already lost, it could compound your losses. And it is an area that I think in talking about over and over again in that patient responsibility side. And I can tell you that as we've gone in and worked with different groups, trying to help them see what's going on with their revenue cycle management and why their AR is so high, that ultimately it boils down to 2 or 3 things in each case. And most of it has to do with workflow and practice on the other side. But it always starts at the front desk, almost always. I should never say always, but it almost always starts at the front desk. And whether it's a miss in demographics or it's a miss in collecting patient balances or missing the credit card or the patient's mobile number or their email address, all the things that we use now to collect from the patient. And once you've exhausted those first 3 invoices as you're chasing money, it's becoming harder and harder to collect for those. You're already, when you turn it over to collections, looking at pennies on the dollar. But it's just, as we start to see this, and as we start to see if the Medicaid changes go through as proposed, we're going to have more and more of those individuals that you see that don't have coverage, or we're going to be seeing people that have waited longer to get their disease stages treated and need more intervention or more expensive intervention. And all of those things are going to add up to patient direct collections. And that's going to make the burden even higher on the physician practice, and the importance of what your front desk does even more important.
So what are some actual tactics that you can share with us as you travel across the country, have seen what actually works and what doesn't work?
So credit card on file is a wonderful tool. And there are plenty of applications out there that allow you to store a credit card securely. And so I'd look at that as a big issue, but it also means that your financial policy really needs to be strong in saying, I'm going to have a credit card on file, and any balance that you have, if you don't pay it voluntarily, we're going to run your credit card. And if that credit card does not clear, then you will not be seen again, and we're going to take the actions to collect that. So a good, strong financial policy and a good credit card on file tool. The other one is everybody has a cell phone. The cell phone collection tools out there are stronger. And so in addition to, and I would say, if you can, rely primarily on mobile phone or texting with easy click payment options. Email is another one that you can do, although we know our email is clogged. Those are both cheap ways to continue to ask the patient to pay their responsibility. Ideally, you collect everything up front. So that's the other way to do that. I'm not seeing practices as well organized in that way, but I see some. And, the more you can give the tools to your front desk, even from the data that they need to have to the scripts that they use. Not how would you like to pay today? Are we going to be using your credit card on file to pay this? Use language that makes the patient actually respond with, or which method are you going to use to pay today? Not a choice not to pay. You've got to give them a lead in that makes their response more likely to give you a credit card, a check, or cash. And that should be done before the visit. It should be done based on estimates. And then you'll need to have an aggressive refund policy for things that are over collected, and refine your tools as you go. Make sure you can get closer and closer so you're not having to write as many refunds, so that you know what those deductibles are and what those balances are for those particular patients, especially when it comes to your high volume contracts. So those are probably some of the bigger ones that we're looking at. Phone calls and chasing and mail are really antiquated, outdated, and not as successful as using in-person, text, or email.
Yeah, the marketers kind of ruin everything for us when it comes to communications. Initially, it's the postcards, the mail, and then the phone calls, and then the email. So we get bombarded with spam. So nobody wants to open those things anymore. The best way to communicate with your patients nowadays is SMS or text messaging, simple messaging system. To get your financial ducks in a row to collect effectively, I agree with you. Using text messaging is probably the way to go. And the better way to go, as you said, is to collect up front. Yeah. And I know you've been preaching this for many years, over a decade now. I do it. I've been doing it for a long time. So it's easy for me to say, yeah, just collect up front. But actually implementing that requires work.
It does.
Ray, you had some thoughts?
It's been a long time since I've told you the story, but you guys have given a good conversation. And Mark mentioned it all starts with the front desk. And I'll tell you a story about Helen. Helen was my receptionist. Now, she was young. Her thought process was a little unusual, but this was back in the day before EMR. So I was standing in the chart room right off of the front desk, reviewing the chart for the next patient, as this little old lady came up after she had finished her treatment. And Helen's reproach was, okay, Mrs. So-and-so, you want to pay by cash, credit card, or check? And this lady went through sob stories. Her dog was sick. Her husband was sick. I was sitting back there just about crying. I was ready to write the whole thing off. But Helen just kept going. Every time she'd smile and and how are you going to pay today? Cash, credit card, or check? And after about the fifth trial, the little old lady just pulled out her check and wrote a check. Yeah. So it does start with the front desk and how you approach it. But now there was one other thing you didn't mention, Mark, that did work in the old days. I had an arrangement with a lawyer that I paid him a few bucks for every letter I sent out. And the letter would just, at the end of the 3 months when they haven't paid, it would be a threatening letter from a lawyer. And that was very effective back in the old days. Are they using that now?
There are still states where you can do that, but unfortunately it's not universal anymore. Those threats are, at least on face value, they could be effective, but there are some states where you can't do that in the same way that you used to. So you got to be careful where you are as to whether or not that's a tool you can use.
You mean you can't warn them before you turn them over collection?
So I tell you what, it's getting complicated. It really is. The way people have been bankrupted from medical debt and the reactions of the state legislatures have taken some teeth out of this. So it is one of those areas where it's not that you can't threaten necessarily, but it's that there's not much teeth in that whole thing. If the patient doesn't feel like they have the wherewithal to pay and they think they can hide it in, there aren't really things you can do that can actually affect them like we could before some of these laws had been passed.
I think the bottom line is do everything you can to determine patient responsibility before the visit and then collect that at the time of service.
Yes. Or get a credit card and get that payment plan as the second step. Get the agreement in, get those hard things, get those hard discussions in up front, one way or another.
I totally agree. I've always stated that doctors should do charitable work. We do see patients that can't pay that need our services, but it should be done up front, not 90 days down the road. So have that discussion up front. Fortunately, I practiced in an area at a time when a patient said he had a problem, you could believe it. I really am happy I'm not practicing today where you can't trust the patient and what they tell you at times. But you still need to have that discussion and make the decision up front.
There certainly are some people who are malingerers and go to healthcare facilities for secondary gain. Ready to level up your urology coding and reimbursement game? Are you leaving money on the table? Confused by the latest coding changes? Want to know the next revenue opportunities for your practice? The Urology Advanced Coding and Reimbursement seminars are your key to unlocking maximum compliant revenue. Join the nation's leading experts for our intensive twice-yearly seminars. You'll gain practicable, actionable strategies to navigate complex guidelines, master documentation, and conquer claim denials. Whether you are a seasoned office manager, coder, urologist, APP, or new to urology, these seminars are designed to empower you and your practice. Don't get left behind. Visit prsnetwork.com to secure your spot at the next Urology Advanced Coding and Reimbursement seminars. Invest your expertise, invest in your success. I know you just heard the promo for the upcoming Urology Advanced Coding and Reimbursement seminar. There will be some major prostate biopsy code changes starting next year. This and other topics to keep you current and viable will be addressed during the seminar. I highly encourage you to attend. Should we go on to the third question, Scott?
You bet. Let's hear it. What do you have for number 3?
All right, here it goes. Our office will be beginning PAE, prostatic artery embolization, for BPH in the near future. This will be performed in the office, place of service 11, by an interventional radiologist who will manage the sedation and the performance of the actual procedure. We have not had to bill for conscious sedation in the office before. I was hoping to get some guidance on what codes should be investigated for the anesthesia portion, such as the administration, medications, etc., so we can better prepare ourselves for what is to come. What say you, Mark?
Yeah, so as we've been ramping up PAE with different groups, it's been an interesting path for sure. So there's a lot of things to consider. Specifically on conscious sedation, one of the things, the two codes we're really looking at primarily are 99152 and 99153. They're 15-minute increment codes. The 52 is the initial and the 53 is each additional 15. So those are your main codes that you're going to look at for the conscious sedation. And ultimately, the documentation that you're going to need is the physician has to be present throughout the entire time frame that there is the supervision that is being provided. So your documentation needs to support that the physician was there at the initiation of the conscious sedation and remained there until the patient was taken off the sedation and moved to recovery. So there is that documentation piece that needs to be included, as well as, of course, the method of delivery, whatever pharmaceuticals you were using, who else was helping, if there was a nurse, those types of things, and the time. So those are the elements that you're going to have to put in your documentation. And then you're going to end up calculating how many units are on the 99153 based on the overall time the patient was under conscious sedation. So that's that piece of it. The other thing I will mention is this journey of PAE has been interesting to us in two different ways. So number one, the actual IR physician, we have found, tends to do things a little bit differently from case to case or from physician to physician. So as we've looked at trying to develop a pattern of specific codes that are typically used for the performance of PAE, which is an entirely different discussion, it really does take reviewing how your IR physician works and how they document. And we have found, as with other physicians, that they have been given advice on how to code that may not actually apply appropriately to the way that they are providing the service. So it does take some guidance to build those in, but focusing back on conscious sedation, those things that I mentioned right at the beginning, the physician presence, the overall time, as well as any assistance, method of delivery, drugs used, complications, of course, those all need to be documented. And then your time calculation is what you use for the codes.
It
I got
sounds
a
like,
question on time.
yeah, go ahead.
If you, that end time, if it's like 8 minutes as opposed to the 15 minutes, is that do you bill the extra unit or not?
So you want to know the total overall minutes. And actually, I was going to say, well, I don't have time to answer that question. But yeah, you want to make sure that you're using the overall times, but you should be unit wise rounding to the nearest level. So 8 or more goes up, 7 or more goes down because it's 15-minute increments. So you got to be over 50% for that. But you also want to watch your contracts because there are a couple of payers that want the full 15 before you get the 15.
Okay. So you're saying is payer dependent.
As with anything, make sure you understand your contracts.
Yeah. Oh, so
And the last one I'll add is if you can find that anesthesia support to get your right folks in. I mean, that's the other side of this is some people are having trouble getting the staff to help them.
in this situation, what I'm reading here is that the interventional radiologist will be doing the sedation and the actual procedure. So from what I'm hearing from you, the interventional radiologist will need to document the anesthesia process, note the time, note who's there helping, and actually code the procedure for the actual PAE.
Yes, it will fall under the IR doc. And what we've seen from most of the reports is there's usually a nurse or an assistant that really kind of runs this with the supervision of the physician. That IR doc usually has somebody helping them, which is the other piece of that documentation that you need in that process, which is why I wanted to focus on that.
Sounds good.
Okay, let's move on to the bonus topic. If it sucks, can you bill something extra?
Oh, this is going to be big.
All right, what does that mean, John?
All right. I received an email from a surgery center recently, which stated the following. Recently, we have been using a larger number of disposable ureteroscopes, which are very costly to the center. In order to capture the code C9761 for reimbursement of the disposable flexible ureteroscopes, we need your dictation to reflect the usage of that scope and that suction aspiration was used. A vendor's representative was there and provided a few examples from other physicians that have resulted in successful reimbursement of these scopes. Below are the examples. Number one, The op note documents a steerable and suction/aspiration was used. It says a disposable single-use flexible scope with steerable and suction aspiration was used to improve stone-free rate. Number 2, the op report documents only a scope using a suction feature. It says a flexible disposable ureteroscope utilizing a suction features was utilized for the procedure. If you are not already, please have your dictation reflect that you are using a disposable flexible ureteroscope with suction so that we can bill for reimbursement. As always, we appreciate your help with cost containment and appropriate reimbursement for the center. Please let me know if you have any questions or concerns. Mark, what say you?
So it sounds like this directive came from the facility,
Yes.
who it gets to bill that extra C9761 if a flexible ureteroscope with suction capabilities is being utilized. So that's really, I think that piece is the part that they're really trying to lock in with this documentation. And it is important to make sure that you do include that you used a specific type of device. And ultimately, the disposable single-use flexible scope is where that code is. But it does need to have suction or aspiration to do that. Now, I don't think you need to add to improve stone-free rate to the actual use of the scope. That is something that probably should be included in your medical decision-making as why you chose to use it. And I think that can be supported in the medical necessity side of your operative note. So I think you could make this piece, which again is really focused on making sure that the center is going to get their reimbursement or their appropriate reimbursement. Something with a disposable single-use flexible scope was with steerable and suction aspiration was used for the procedure. Is that one type closing macro, if you will, that you would put into that note, in addition to your standard operating note as to what you did in your procedure and why you chose to use suction aspiration in that summary.
Now, with the use of C9761, that is a specific code. Initially, I think it was Calixo that applied and got this new C code. There's also a transitional pass-through code just for the single-use ureteroscope, which is C1747. In this situation, as described, do you think C9761 is appropriate?
So in this situation, did they actually use the disposable scope?
They used so there are now flexible ureteroscopes that have suction built in.
Right.
But there is no steerable ureteral catheter that was used as described. The urologist simply used a flexible scope with suction feature built in.
Well, that doesn't work.
Not a steerable ureteral access sheath.
Yeah.
So let's go back to the definition of C9761, if you will.
Okay.
So C9761, cysto-ureteroscopy with ureteroscopy and or pyeloscopy with lithotripsy and ureteral catheterization for steerable vacuum aspiration of the kidney, collecting system, ureter, bladder, and urethra, if applicable. Open paren, and I emphasize this, must use a steerable ureteral catheter, close paren. So that is C9761. Whereas C1747, endoscope, single use, that is disposable, urinary tract imaging illumination device, insertable. So those two are very, very different.
Yes.
And what the surgery center is asserting is that you should help us code for C9761 when in fact I never used a steerable ureteral catheter in my cases, and yet somebody's telling them they should use C9761. That is my
they
issue.
cannot. They can't.
Yeah.
That is, and we've actually, as you know, we've written about this a couple of times in Urology Times. as we've gotten questions there. And yeah, you have to meet that full definition. If it's not steerable, it's not C9761 appropriate. If it's disposable and it's suction and it's ureteroscope, or it's a disposable, then, and it doesn't even have suction, they still go under C1747 if it's not steerable. If it's steerable, but it doesn't have suction, it doesn't fit C9761. So you've got to have both capabilities in order to use the C9761.
Yeah, so I just want to clarify for the listening audience, if you're using a disposable ureteroscope, whether or not it has suction built into the ureteroscope, it is still just C1747. But if you're using something like Calyxo, Cleopatra, etc., where you have a steerable ureteral catheter and you do the appropriate ureteroscopy, etc., then you can be considered for C9761. And also the other thing is, just because the vendor says that you should include this language doesn't mean that you actually will be paid appropriately for the code that they suggested. And Scott, do you have any resources on how urology practices and maybe vendors can better navigate this crazy coding game?
Thank you for bringing that up, because just because the representative says it doesn't mean it's actually true. So you got to really, trust but verify, unfortunately, with all your vendors out there. So what we've done and what we've created and we're building out, and we're going to be continuously building out this entire year, is our PRS Coding and Reimbursement Hub. And what we do on the hub is we as PRS are going to verify the information that the vendors are putting out there. We're going to do the research on our own and put up our interpretation of what you need to do in order to get paid for the services you're providing. And in this case, for kidney stones, and if you're looking at a kidney stone with a steerable scope, what does that take? And do can you bill the C9761, or do you have to stick with the C1747? So that's what the hub takes you through, that discussion. So then you don't have to go out and do all that research. You can look at what we've put together. And again, that is what we're trying to make this whole system much easier to navigate, because we know there's a lot of great technology out there, but if there's hesitation on reimbursement, the patients aren't going to get the technology they need to get their problems solved. If there's a good technology out there, we want to make sure that reimbursement is there for the physicians so you don't get burned. So you can go to the PRS Hub, which is prsnetwork.com/urology hub, and you'll see we're building that out. So we got a few topics up there, a few products up there, but we're adding more and more each month.
It sounds like you're bridging the gap between the technology itself and actual implementation and making sure that everyone is made whole.
That is exactly true. And I always tell the story that the first question a urologist asks is it good for my patient? Is the clinical side of whatever technology out there, is it good and will it help my patient? Well, very closely behind that, it used to be question 1 and question 2, but now it's question 1A and 1B. So 1A is it clinically good for my patient? 1B is, am I going to get reimbursed for this appropriately? And so that's what we want to really address on the hub and make sure that that's very clear.
And it's helpful for the, I just want to point this out, it seems like it's helpful for the urologist so that he or she will be appropriately reimbursed. And also it's going to be helpful to the vendors so that their technology will actually get in the hands of the urologist to finally benefit the patient. Because if there's no reimbursement path, that technology might as well as not exist.
That is so true. And if you look at the motivation of a vendor, they want to get more products into to treating the patients, but there's their interpretation of the reimbursement may be slighted toward that, as opposed to what we can do is we can really vet that information and give that honest opinion.
So we were, you and I, and also Mark, were at the AUA's Innovation Nexus, where a bunch of startups get together and try to share their information, share their new products and service. It has become abundantly clear that a lot of these guys, inventors, founders, have a passion for their product, but they're quickly realizing that if there's no payment for that product, the product is never going to launch.
Okay, let's wrap this episode up here. Let's get some final thoughts. And we're going to save the final word for you, John, as our special guest. But we want to start. Mark, final thought.
Yeah, it was fun to cover some varying topics today. And thanks for bringing them up, John. And it's always good to have you on to bat through all of these different issues that are out there that we're facing today. So, I think in the end, we talked about a couple of things surrounding coding with the ER visit and the conscious sedation that again go back to what we've always preached. That documentation component and the context of why you're doing and what you're doing is absolutely essential in the reimbursement side. And understanding the clinical language and how that has to be married up with the financial language, if you will, of CPT to get paid for all that you do is becoming more and more important. We're running into downcoding exercises, all this stuff that the AI is driving the insurance companies to make your life more difficult to get paid, all is basing on more and more review of your documentation. So you can't avoid that exercise. Utilize all your tools that you've got, cheat sheets, templates, forms, AI, all of those things, but make sure that those tools actually reflect what you're doing in the office setting and give you the support that you need to not only treat your patients, but to get paid for the services you provide, because that's what you're doing for your life. So that would be the first thing. And then the other one is, the other part of this is making sure that you are collecting from your patients is absolutely essential. A third of your income. And if you're talking about what we're seeing now as an average practice somewhere at 60 to 65% overhead, that really translates into almost half of your take-home pay comes from the patient. So it is not something you can ignore.
Ray, final thoughts.
It's always fun to listen to Mark and John in a discussion. John brings a very learned and knowledgeable discussion from the private practice standpoint. And Mark is looking at what's going on from a national level. And again, that was a good reason for you to attend the seminar in September, because it's always fun when they get into a discussion of what should happen. And I might just add one little thing to the coding of the ER discussion. In the very beginning, there was a lot of discussion on the ER code. You can't use time, you have to use medical decision making, and what you're going to do about the problem and the data. But I would add, you probably are going to have a prescription drug management. If you don't give them a trial and an erection drug for a 19-year-old for erectile dysfunction in the ER, you're probably going to have to give him some anxiety drug.
Yep.
All right. All right. We'll let the last, John, you got the last word.
All right. I'll take a more macro approach. I'll share a story with you. I know a local large practice with multiple facilities and multiple offices. They are still not using the code G2211. No. And I've offered my services. I said, I will come in here to help you train your staff, train your urologists at your quarterly, monthly, whatever meeting, so that you can start implementing this. And I've talked to their stakeholders, I've talked to the office manager, and they're still not doing it. So the reason I share this story with you is that this is costing them hundreds of thousands of dollars. and that I totally get it. Change is difficult. I'm also dealing with older parents and also in-laws where change is resisted in life. The only constant is change. So as I'm getting older, I hope I never get to the point where that I would just reject change wholesale. Change is part of practicing urology. Change is part of life. Learn about the changes, adapt, adopt, and thrive. Back to you, Scott.
Well said. All right. We want to thank everybody for listening to this episode today. We appreciate you taking your time. We also want to thank ModMed for supporting this episode. That's all we have for today. Take us out, John.
Happy coding, everyone.